The administrative costs of the Canadian healthcare system, they reliably implied were just 1%. Well, they needed to come and have a closer look at the Canadian healthcare system. The number one thing you need to remember is that the quality is not constant. The product is not. The reason why you don't want to have one automobile producer and have all that inefficient different, the reason why you want to have them is because competition is not inefficient. It produces better quality. It makes sure the automobiles are there. Not like in the Soviet Union where, you know, you had to order one 15 years in advance and all that kind of stuff. Monopoly providers don't work. Competition works, and that's why you have to put up with that extra cost of the competition. The NHI, I'm nearly finished. The NHI plan should be comprehensive. Well, this is not okay, and this is the final point that I need to make with you today, and this seemingly innocuous provision of the plan is really the one that will do you in. Well, first of all, there's the issue of the cost of insuring for oil change, because what they do say is everything should be included in this plan. We want to be comprehensive, so everything should be included. So you're going to insure for oil changes. That's the number one problem. But the second one is that you're going to eliminate the private option. Now, I don't know how many people here are aware that that's what, in fact, is intended by the program. But what the program says is that private spending will only be permitted for services which exceed or are not covered by the NHI. In other words, you will not be able to pay money in the Bahamas. You will not be able to put your hand in your pocket if the government is not providing the service. It says it's providing, it's included in the comprehensive envelope of the national health insurance, but in fact they're making you wait 5 years for it. You will not be, under this law, if it were to be put in place, you will not be able to take your own money out of your pocket and go to a doctor and get it done, or go to a hospital and get it done. You will not be able to do that. That is what the Supreme Court of Canada was talking about in the Canadian system. That this comprehensive, nationally administered, universally available system precludes the existence of, and why do they want to do that? Well, it's ideological, ladies and gentlemen. They want to make sure what Winston Churchill called the equal distribution of misery. They want to make sure that nobody can opt out. That you, if you're wealthy, of course you can opt out, you can fly to Miami, but you won't be able to do it right here. You won't be able to go down the street and jump the queue and pay for your health care services yourself, if it's covered, if it's notionally covered under the national health insurance. Now, I have to tell you that this little clause, in the case when Hillary Clinton came with her plan in the United States, at the very 11th hour of its consideration, a group of us who were working with the Center for the New West out of Denver discovered this clause in the thing. And we made that available to people, and people finally started to realize what she was trying to do. And that was what killed what they called Hillary Care. Not Hillary Care, yeah, Hillary Care, yeah, Hillary Care. Hillary Care, it sounds kind of funny, but Hillary Care, yeah. That's what killed it, was the recognition by people that this was what was really proposed. And you need to realize that that is what is being proposed here in the Bahamas. If you think that because they say the public health care system will enter into contracts with private suppliers, that means you're going to have a parallel health care system, forget it. You aren't. They're going to turn your private hospital into a public institution. And they'll do it over a number of years, and what they'll do is this. They'll say, okay, you can produce X number of gallbladders and X number of appendectomies and all that kind of stuff. Okay, so we'll pay you this amount. Okay? That's what the first year. Second year, oh, well, guess what? We're going to reduce that a little bit. Oh, you can't make your budget. Oh, dear. Well, we'll give you a subsidy. Oh, well, now in the fourth year. Oh, well, now that we're giving you a subsidy and we're really determining what you do, it's not much point in having a private thing, is there? Now, you think that what I'm telling you is something that I'm making up. When we went into our program in Canada in 1970, we had mostly private hospitals. They were run by the Salvation Army, they were run by the Catholic Church, they were run by the United Church, they were run by communities, organizations, by Kiwanis clubs, they were run by everybody. They were not for profits, but they were private. We don't have any more private hospitals in Canada. Well, we have some now that are emerging, but of those of that original group, they all got taken over one way or another by the Trojan horse of the finance which the government provided, and there is no option. This is the provision which is most sinister in the report, and it is the Achilles heel of the Canadian model, and is recently rejected by the Supreme Court of Canada. Finally, contributions set at a level affordable by the majority. Now, that's what the Blue Ribbon Commission says in its summary. It says that there's going to be, that's the words they use, contributions set at a level affordable by the majority. But then when you dig into the detail, what do you find?
Wow, I wish we had time for questions and answers, but I'm going to invite Dr. Sweeting to come up and give the vote of thanks.
Dr. Walker, if this was one of our local church settings,